Hello, everyone. I'd like to take this opportunity to welcome you all to part one of the three-part webinar series on Navident 2.0 TaP, Trace and Place Technology, a paradigm shift in dental surgical navigation. So we have a global audience here this evening, or for some of you, I guess, this morning or this afternoon. Many of you are current users, and many are hopefully future users of Navident after this evening. So the paradigm shift alluded to in the title refers to the registration of the patient CT data to the actual patient prior to navigation. TaP, or Trace and Place, refers to our new trace registration technology, which we here at Claronav are very, very excited to introduce to you all. The overall TaP process and its many benefits will be explained in detail this evening, with the subsequent two webinars focusing on specifically its application in the maxilla and the mandible, respectively. So the most obvious among TaP's many advantages is taking what was formerly, and the current users can ascribe to this, what was formerly a 20 to 30 minute pre-surgical registration process and turning it into a 2 to 3 minute process that fits very nicely and easily into your regular surgical workflow. So leading us through tonight's webinar will be two clinicians that you'll be very familiar with if you're a member of our current Navident user group. Dr. Bermanis is our Director of Clinical Operations here in the headquarters at Claronav, and Dr. George Mandelaris is a Navident Master Clinical Trainer, Lecturer, Author, and Periodontist Extraordinaire from Chicago, Illinois. We're going to start with Dr. Bermanis, giving us an overview of the TaP technology. So Dr. Bermanis has a broad perspective on the dental industry, gained from his 13 years as a practicing dentist, obtaining a master's degree in biomedical sciences. His research thesis focused on development of an innovative CT-based 3D biomechanical model of the human mandible, designed for biomechanical orthodontic research. Dr. Bermanis, please go ahead.
Thank you, Jason. So as you mentioned, on today's webinar, we are happy to present Navident 2. As you probably know, since the introduction of Navident to the market in 2014, we had 5 major releases. In all 5 releases, the workflow consisted of 4 basic steps, which were the preparation of the stent, CT scanning of the patient with the stent and CT marker or fiducial connected to it, importation of the scan and creating the implants plan, and finally placing the implants under Navident's dynamic guidance. One of the fundamentals of surgical navigation is the registration or the mapping of the CT scan to the actual patient. This is traditionally done by scanning the patient with this fiducial or CT marker in their mouth. And when the scan is imported into Navident, the fiducial's image is identified and registered by the software. During the surgery, when the camera is tracking the jaw tag, this registration is what connects between the jaw tag, representing the actual patient, and the patient scan. The end result is our ability to track the patient in real time, so even if the patient moves during the surgery, we can still navigate accurately with our surgical instruments without having to affix the patient in place. In order to accomplish that, we had in Navident 1 to mold the stent, connect the CT marker to it, secure it on the patient's teeth, and CT scan the patient. During the surgery, we had to make sure that the stent, now holding the jaw tag instead of our CT marker, is seated in the exact same location and position in which it was during the scan. So what has changed? If previously we had to prepare a special stent and to have an artificial fiducial attached to it for the CBCT scan, we now don't need that anymore. In Navident 2, instead of the traditional artificial fiducial, we can use already existing structures that are rigidly affixed to the patient's jaw as our natural fiducial for the registration of the CBCT scan to the patient. That means there is no need for a special stent, and also we don't need anymore to take a special CBCT scan. The diagnostic CBCT scan can be used for the planning and navigation. So our new workflow starts with the importation of the diagnostic CBCT scan into Navident. The crowns and implants are planned as usual, and then we choose 3 to 6 distinct rigidly fixed structures, such as teeth, crowns, or abutments. These structures have to be visible in the CT scan as well as accessible for tracing in the patient's mouth, and we mark them in the software on a virtual 3D reconstructed model, which is stretched like a panoramic view on the screen. These landmarks we place will be the points from which we will start our tracing in the patient's mouth just before the surgery. All the steps described so far, the importation of the scan, the planning and placing of the landmarks, can be done prior to the surgery without having the patient present. Although we do not attach any fiducial to the patient's jaw, we still need to allow the camera to track it, so a tag has to be connected to the jaw. Since in most cases the maxilla is well connected to the cranium, a head tracker is placed on the patient's head. The tag is installed on special eyeglasses, supported by the nose bridge, with elastic ear hooks, and once placed, it is extremely stable and cannot be easily moved by the patient's motions. When navigation is done in the mandible, a jaw tracker tag is installed. This tag has a bendable stainless steel wire, which we first bend in order to bring the tag to its desired location next to the patient's jaw. Then we temporarily attach the end of that wire to 1 or 2 mandibular teeth with a dual cure composite resin. Usually we do not need to etch the tooth first, and at the end of the navigation we can easily remove the tag with the composite off the tooth. This tag can be used also on the maxilla if we'd rather use this instead of the head tracker, and we will go into more details in the next webinars. Once the tag is installed on the patient's jaw, the tracing can be performed using the tracer tool, which is actually a burnisher with a 1.5 millimeter diameter ball tip connected to a tag which is trackable by the camera. After a very short calibration of the tracer, we trace the teeth that we have selected before one by one. For each tooth, Navident collects 100 points, and the whole tracing process takes between 60 to 90 seconds depending on the number of landmarks selected. Right after the completion of the tracing, we do an accuracy check of the registration to make sure that we got an accurate result. The blue circle represents the ball tip of the tracer, touching on the outer tooth surface, where we actually touch with the tracer itself. After the registration, the workflow continues as usual with drill calibration and navigated osteotomy. We have some new physical components used for trace and place. The head tracker that we mentioned, placed on the patient's head for maxillary cases. The jaw tracker is the tag used for the mandibular cases. It has a stainless steel positioning wire, which we can bend using the supplied bird beak pliers, and it connects to a mandibular tooth using an off-the-shelf dual-cure composite resin. The tracer tool and tracer tag which connects to it, and a new calibrator tool used for calibration of the tracer, the surgical handpiece, drill axis, and drill tip, and now also calibration of piezo tips and calibration of a high-speed handpiece. To sum up the benefits of trace and place: less cost, no need for a special CBCT scan, less time since we don't need to spend time on preparing a stent and scanning with it, so also less radiation to the patient and fewer pre-surgical preparations. The assistants do not have to make stents anymore, so it is more surgeon-driven. Since the step of scanning with fiducial is eliminated, there is less potential for inaccuracies. Without the stent, we can now scan the patient in full occlusion, which makes it easier for a virtual prosthetic planning. If we do not have a CBCT scan in office, it wouldn't make it difficult for us. And the registration errors can be easily corrected. We simply repeat the registration. And lastly, the surgical area is kept wide open without stent interference. As always, there are still some considerations that need to be taken into account. First, we must have at least 3 high contrast surfaces of teeth or abutments or crowns affixed to the jaw, in the CBCT scan, which are also available and accessible for tracing inside the patient's mouth. If a flap is to be reflected, it can even be the ridge itself. Secondly, the CBCT scan has to be relatively new because we know that in certain situations, some teeth may change their position over time or change their appearance in case that a new restoration has been done since the scan was taken. And thirdly, once we did the trace registration and verified it is accurate, we need to make sure that the tags remain in fixed position relative to the patient's jaw. As always, we need to perform regular accuracy checks prior to each drilling to make sure that the tracking is still accurate. If it is not accurate, we simply need to repeat the registration. Thank you, everyone. This was just the overview, and on our next two webinars, I will present our trace registration workflow in detail. Next is Dr. Mandelaris' part. Back to you, Jason.
Thank you, Ido. Thanks very much. It's great to have an overview. Many of you are very familiar with our Navident 1.0, and a few of you have had the opportunity to see a Navident 2.0 in action, and a very few have actually had the opportunity to use it. One of those people is Dr. George Mandelaris. So George has been with us and been a user of Navident for well over 2 years now, and he's been actually very instrumental in helping us to test and develop several new innovations based on his own and other user feedback. The users, some of you that are in the audience right here today. So George attended the University of Michigan from undergrad through dental school, and in 1999 completed a 3-year postgraduate residency in periodontology at the University of Louisville School of Dentistry, where he also obtained a Master of Science degree in oral biology. He is one of our top go-to people in the world. There's a few others like him that are going to be working on the beta testing starting right away. And as Ido mentioned, and as we all mentioned, we're all very excited to see George's presentation and to get TaP out with Navident 2.0 to all of you. So George, I'll leave it to you.
Great. Can you hear me okay? So, well, thank you, Jason. Thank you for that introduction. I just think this is fantastic. It's very exciting technology. As some of you may know, or maybe not, I've certainly been involved in guided surgery for a long, long time. I joined a practice in the Chicagoland area that was kind of on the leading edge of using CT scans for implant surgery for a better understanding of regional anatomy. That then led to kind of the development of Simplant static surgical guides, and has kind of brought me to this point of incorporating navigation and really the next step in guided surgery, if you will. So I'm going to just kind of share with you my perspective of Navident and dynamic navigation. I'll spare the historical perspective. We'll talk a little bit about accuracy and precision and why I feel this is so important today, and why it's perhaps an emerging problem when we don't follow the protocols. We'll talk a little bit about navigation, as Ido did. I have a few videos that I want to share with you. And of course, the focus is going to be on trace in place, the technology. So, there's this kind of synergy that has to be infused from what we can do on a computer software program and what we actually can do on the patient. There's the synergy between the brain, the computer software, and then really executing the surgery. And that's something that takes care, skill, and judgment, experience, and so forth. And above and beyond anything, the adage of garbage in, garbage out remains, no matter if you're using dynamic navigation, static surgical guides, or no guide at all. If you fail to plan, you're planning to fail. And that doesn't go away just because we're using Navident. These are a couple of papers that have recently been published in the Journal of Periodontology talking about accuracy and precision, and why I think it's kind of relatively important. They basically are speaking to the incidence of peri-implantitis and peri-implant mucositis in the development. Certainly we know the risk factors: previous periodontal history of a patient, poor plaque control, genetic predisposition, diabetes, etc. But one of the things that's becoming pretty significant is that this isn't just a once in a month kind of phenomena. This is becoming a more routine thing that we're seeing in our patients today because of the numbers of implants that are going on and the aging of implants as time goes on and as these patients are in maintenance care. So depending on the papers that you read, you're looking at somewhere between 3 and 47% of implants that are being placed today have some level of peri-implant disease, whether that be peri-implant mucositis or full-blown peri-implantitis. That's a difficult thing to treat. As we've read with some papers in the International Journal of Perio and Restorative Dentistry and the International Journal of Oral and Maxillofacial Implants, some of the things that are being uncovered is not just the risk factors that I shared with you earlier, but actually some of the things that are happening in the clinic on the spot that could be preventable errors that are happening that contribute to peri-implant diseases. And these are modifiable factors that are called triggers, more or less. And there are things that perhaps could be prevented in the surgical setting that can avoid the development of peri-implantitis and improve our surgical execution. The triggers are known as, are seen here as implant positioning, mucosal tissue thickness, the width of keratinized tissue, perhaps the implant abutment connection type, and the amount of loading. But the one that really takes center stage is implant positioning. This paper in JOMI not too long ago, 36 clinical cases, periodontists were evaluating these patients, all of which had 20 years of experience. And all the implants that showed some level of peri-implant problems generally had too buccal of a position. So the implant is really placed too facial compared to where it was planned or where it was intended. In 20% of the cases, the tissue, was relatively thin, and in others, there's minimal keratinized tissue. But an overwhelming amount of the cases, really the fixture is in a too buccal of an implant position, which triggers crustal bone loss, which then exposes the implant surface, which is difficult to decontaminate, and it certainly is more susceptible to biofilm formation, and then it leads to a slippery slope. So today it's really more important that we want to have our implants in the cingulum for retrievability and screw retained access. I think that's really where the profession is going, and where all of us, here tonight, that's what we strive for. But perhaps even more important than that is that implants are being placed pretty routinely in young patients, patients that are in their 20s, and these are fixtures that we're telling patients that they're going to have for decades. And there is an effect of craniofacial growth that needs to be considered from a retrievability standpoint. If there is some growth, the fixtures or the prosthetics are going to have to be replaced at some point, and these are considerations that need to be underscored at the development of a treatment plan. So it's even more important to really have this prosthetically directed plan well-centered and well-executed throughout treatment, and to have the fixtures in a retrievable position for the future. Certainly the younger the patient, the more important that is. So computer-aided implantology, navigation, this is the next level, and something I'm very, very excited about. In fact, it was something I was so excited about, we actually put it in the American Academy of Periodontology's Best Evidence Consensus paper that was published in October of 2017 in J-Perio. So imaging today is now standard of care. It's standard of care for patients receiving implant surgery, certainly in the periodontal realm, I know in the oral and maxillofacial surgery realm, and in any other disciplines, this is now standard of care. And in fact, it's one of the modalities that really is necessary to execute surgery with navigation or with certainly static surgical guides. So there are 5 components to the navigation system. There's a laptop computer that runs the planning and the guidance software. There's an optically marked handpiece, or what we'll call a drill tag. The optically marked patient attachment, or the jaw tag, or as Ido was showing you, the maxi-ref, the head tracker, and in the mandible, the jaw tag. There's an optical position sensor, the micron tracker. That's really the guts of the system. And then a mobile cart that maintains the laptop and the micro tracker, as you see here. So with TaP, or trace in place, we have a head tracker that he showed you, and I'll show you again, and then the jaw tracker in the mandible, which is affixed by composite resin. As you see here, I'm working on a patient in my office. And this was the first generation head tracker that was used. It looked like a little Y, but it's basically paired to a pair of glasses. You can see the drill tag here on my handpiece and the jaw tag that is affixed to the lower arch with composite. It does take a little getting used to. It takes at least 30 cases or so to really become proficient. But as we'll share with you a little later on, we have a recent article that's been submitted to JOMI that the accuracy of this technology is as accurate as totally guided implant surgery, if not even more accurate. So the data is emerging and it's getting there. It does take a little getting used to because I'm looking at a computer screen to execute the surgery. So there is a transfer of trust in the technology and in the execution, just like there would be in any other type of modality. So this is a historical perspective here. Just briefly, we used to attach or affix this little attachment for the jaw tag. That's no longer used. As you can see on the right-hand side, this is a W&H handpiece that Navident will work with you on. It's attached with a little thumb screw that needs to be tightly secured so that it's very stable, so that the micron tracker can observe it. This is the old stent system that we used to use to calibrate the access and register the drill tip. Today we're not using that any longer. We've got our jaw tag, as you see here, but I still like to use a belt and suspenders approach. So we're going to optically scan the patient after the CBCT scan. We're going to upload that data to a dental laboratory that we're going to work with to do a digital diagnostic wax-up. The digital diagnostic wax-up STL file will then be sent back to us and registered to the CT scan using the Navident software. We'll stitch the two files together so that when we execute, we're executing from a prosthetically directed position from a mesial-distal, buccal-lingual, and apical-coronal position. Because there's some level of freehand with this, and I'm still using, I have to use basically, I'm using the navigation software, but I'm also looking at a computer screen. I like to just know, I like to have some reference of tooth position. So I'm still using some sort of suck down to make sure and validate exactly what's executed, what's occurring. And this is great for my referral doctor to see this because they know that I'm executing in a surgery standpoint with their best interest at heart, and I'm using the leading edge technology to get it as accurate as possible. So here we are using the tracer tool. The tracer tool is relatively similar to the jaw tag. This is what the micron tracker is reading, and this is the little stylus pen which I'm mapping out the teeth and registering the teeth as our fiduciaries, as you can see there. Irrigation of the area as we work our way through the surgery. Again, the jaw tag here with the composite resin, which was affixed here to the lower teeth. This is the head tracker that Ido shared with you earlier. So from my perspective, this is a huge breakthrough. I mean, I've been doing this for close to 2 years now, and always was frustrated with making the stents. In fact, I took it so far to go to Rome last summer to spend a week with Luigi Stefanelli, who's probably the world's expert with this technology, just to get really good with making stents. And this is just a huge leap forward, and it's a dramatic change in the workflow. It streamlines the process, and it's only going to get better from there. It is important, though, to be mindful of the head tracker and not to touch it. It's got to be stationary, so you have to be careful as you're working around the patient that if this is displaced, that could influence the accuracy measurements. So I can't underscore enough how important it is to continuously check for accuracy to make sure that what's being executed is accurate. And when it is, it's near perfection. This is the calibrator, so we're going to go ahead and calibrate our drill axis, as you can see there. There are little rectangular platforms here which you'll register the drill tip, and there's a little nipple here which you could use for registering a piezosurgery tip. So here's the drill tip being registered to the system, and then I'm doing my accuracy check. I'm checking the drill tip. Before this, we're going to do the same thing with the tracer to make sure that what we've traced is accurate, and then what we're registering is accurate as well before we start the osteotomy site. So if I know that the drill tip is sitting here at the facial surface of tooth number 26, and the computer is showing me that I'm all the way through the lingual or in the pulp of the tooth, there's an error somewhere. That's good to know before we start because we can correct that. With static guides, that's an issue because you usually don't find out until after the fact. This is the viewing screen that Ido mentioned to you. It's really pretty amazing because essentially I can see here that I'm 0.3 millimeters away from my entry point. I'm 0.8 degrees in terms of an angle discrepancy, and I have another 8.3 millimeters to go to complete the osteotomy site preparation. Again, this is the target view showing you all the views of the site. So the process used to be create a stent. That was a bit of an arduous and kind of frustrating task. Scan, plan, and then place. And now that's gone, and it's all about scan, plan, place, or trace and place. So 3 steps, pretty simple and relatively intuitive. So trace and place, we're going to register. The registration is accomplished using a recent CBCT scan with the Navident software. And then using the tracer, as Ido showed you, there's 3 reference points. There's actually 4 now. There used to be 3. There's 4. So we have a plane that's preferred. After the registration process, we'll do an accuracy check. Again, accuracy check using the tracer. And then after you confirm that the accuracy is correct using trace registration, we go ahead and calibrate our access of our drill tip with the handpiece alone, and then register the drill tip and another accuracy check before osteotomy site preparation to begin the process. And once that's all confirmed, we start the surgery. So this is basically what's happening. There's the micron tracker is basically registering, it's evaluating the patient, the head tracker or the jaw tag, and then my handpiece, and it's giving feedback back to the computer, and I'm able to see exactly what's happening in real time. So for me, this is really the next step forward. I mean, the ability to have real-time verification and validation of positional accuracy on the spot transparency is 100% the next step forward, and that's really exciting. So again, you've seen this, the head tracker, the jaw tag. This is the W&H handpiece, which the jaw tag is attached to. There's a thumb screw here that'll attach right into there, just as you see here, and then this is the tracer tool. That's how it'll be attached, and that's got to be very stable. So here we are with the tracer tool. This is the trace in place. This is the registration tab, as Ido showed you. You'll have 4 points to reference, and then we'll do an accuracy check and begin the surgery. So I'll just kind of carry you through a couple of movies, and I'll kind of run through these quickly for you. But you can see here that I'm registering the tracer to the system. It's picking that up and making sure that it's registered. Then I'm going to go ahead and select my teeth that I want to trace. Once I've got that stylus pin on the teeth and the camera has recognized it, I'll then go ahead and map out the tooth, just like I'm kind of using a paintbrush, essentially, and the micron tracker is reading that up till I get about 100 points, and that registers actually really quite quickly. Once the 4 points are registered, then we do an accuracy check, and then we're ready to move on to the next step. Over here, you can see I've already done the access calibration and the drill tip registration, and I'm basically watching once Marcia moves her head, I'm watching the computer screen to see exactly where I'm going to be. She's basically evacuating, looking at the surgical field, and I'm going to be looking at the computer screen here as I begin my osteotomy site preparation. So let me see if I can move that forward a little bit, and there you go. So here I am basically trying to map the bullseye and get it right on the exact position, and then I'll take it all the way down to completion and then move on to the next step. And what also is really great about this technology and this company and this system is the ability to evaluate right on the spot. Unfortunately, it does require another cone beam, but you know, I can kind of see how good I am, and I don't have to have an academic research center or you know, send this off to a place that really is more you know, of a research module that, you know, we really wouldn't have in private practice. Evalunav is actually embedded in the software program, and you can actually register a pre-op plan with your post-op outcome and actually see you know, how accurate you are from an entry point and an access deviation. And it's relatively humbling, actually, when you think you're pretty good, to realize that, you know, sometimes you miss the mark a little bit. But it only drives you forward, and it only gets you better, and it causes you to pay more and more attention. So again, trace registration, the jaw tag, and the MaxiRef, using the trace registration tool here. An accuracy check using the tracer. You can see it's a little bit different than using the drill tip, but you can see I'm pretty much right on the teeth, exactly where I am clinically. And then the drill tip registration, doing an accuracy check, making sure that that drill tip is exactly where I am clinically. It looks good. So we're now going to go ahead and do the surgery. Again, a little bit of a paradigm shift, because you need to kind of look at a computer screen, transfer trust in the technology, and make sure that everything is where it needs to be. I just want to run you through a quick submission. This is some of the articles that's in the literature in terms of accuracy with navigation. From an angle deviation, we're around 3.5 millimeters, and an entry point, 0.87. This compares really quite favorably to static guided surgery, which is totally guided and certainly much better than freehand surgery. But again, to have real-time verification and validation of positional accuracy, to me, is really fantastic and the next leap forward. This is a patient who has full provisionals. He's going to obviously lose this tooth, but we were able to use the orthodontic ligature to trace. So again, I'll just kind of walk you through a couple of quick movies here, just to kind of show you the simulations, and we'll get into treatment in the maxilla at the next webinar, and then treatment of the mandible later on. But again, everything comes back to the planning. So just because we can do this, on the same day, don't shortchange the treatment planning, and don't shortchange the prosthetic need to really have that information into your plan so that you have an excellent result. But again, we're going to start with trace in place, register the teeth. That's going to be our fiduciaries. Where then you can see the maxi reft here. We're going to go ahead and calibrate the access, register the drill tip. Here I'm doing an accuracy check. Once that's confirmed, we then go ahead and move on to our osteotomy site preparation. And again, you can see the accuracy here, and you can see it in real time, which is pretty exciting. Again, Evalunav to kind of show you how good you are on that particular day. And lastly, I just wanted to kind of share with you a study that's recently been submitted. Dr. Stefanelli and myself used much of his data, 231 implants in his private practice, to report on the accuracy of this system. And I think what's interesting is that this is one of the first articles that have actually kind of spoken to the improvement of accuracy as you use the system. So initially, Luigi was around 1 millimeter of access from an entry point standpoint, about 1 millimeter off. But as he got a little bit more, experience with the technology, he was, hovering right around 0.5 millimeters, and almost at 2 degrees of angle discrepancy. So, we're never going to get to probably 0, nor do we probably have to get to 0, but we are getting, pretty damn good, and even better than using static guides. And what's more important is that the standard deviations here on our averages are hovering, within 1 millimeter, less than 1 millimeter. And these are incredibly better than the standard deviations when you look at the systematic reviews for guided surgery. So we had 231 patients, 106 were partially edentulous, 125 which were totally edentulous. These are the numbers. The mean was 0.7 millimeters in terms of entry point, and 2.2 degrees of angle discrepancy with standard deviations, which are really very, very tight. Again, these are some of the numbers that we are reporting on, and so we're starting to emerge with data now to support the technology and actually show that it's completely superior to freehand, but it's even becoming more superior to static guided surgery, and our numbers are just getting better and better. So here are basically kind of the averages of navigation that have been reported by other systems. This is basically what we're able to get with the Navident system, and this is using the old technology with stents. So we're only getting better with trace in place, and I'm sure with the technology that Daron and Ido are developing, it's only going to get better from here forward. So that's just kind of a little bit of a history. I still feel like it's all about the team approach. It's all about the prosthetic planning. It's all about the team. This is my younger partner and I operating together on a patient. I'm in Chicago, and so if you're ever there, feel free to stop by. So just a little kind of history, a little information on my experience with the accuracy and with the system. It's been a fantastic leap forward for my practice, and the reaction from patients has been nothing short of spectacular. It's just been a great thing to develop in the practice, and I think it's only getting us to a place where we can take care of patients on an even higher level of what we'll call servant leadership. It's just been great. So with that, I want to thank you, and thank Ido for starting this off, and thank you to Jason. If there's any questions, I'll certainly entertain anything. And I guess, Jason, what do I do from here forward?
Yeah, thanks, George. That was fantastic. We'll hopefully wait for some of the questions to come and the question and answer. I'm sure many people have a lot of questions about little things. One big theme at the end there sounded like that I heard several times was better and better. So that's great to hear. And, when you're happy, we're happy. And you've been here since almost the very beginning. So it's nice to know and see that you're happy with it getting better and better. And that's what TaP hopefully is going to do for everyone. So if anyone has any questions, by all means, I know there are several of you that have the actual, sorry guys, I'll start my webcam for you. There we go. I know there are several of you that have the software out there. And George, the biggest thing I would say from my perspective as someone who has watched several surgeries and been there supervising, in quotes, or helping, is the lead up to the case when you've made that stent, maybe you made it a day ago, a week ago, the patient's coming in, you're telling the patient all this wonderful new technology and it's brain surgery technology and how great it's going to be, and you put everything on the handpiece and do all the pre-surgical preparations, and when it comes down to it, that moment of truth, when you're going to do that accuracy check with the stent, if it's off, that's it. To a certain extent, unless you're going back to the CT scanner, going to make another stent. But in this case, you just do another trace, right? Or again, as you mentioned, it's very, very mindful not to hit the head tracker or move the jaw tracker, which is very stable. But yeah, if you were to bump the head tracker or were to move the jaw tracker in some way, it's another 2-minute trace, and you're back in business.
In most cases where I've had a problem, I'm the problem. I'm the problem, not the system. I'm the problem, but that's okay. I'm correctable. I'm open to suggestions, and I'm correctable. I will tell you this: when you order a static surgical guide, and again, I've been involved in this for a long time. There is no, you can't go back. What you order is what you order, and you can't make changes on the fly to the static guides. And so for me, having real-time verification and validation of positional accuracy, being able to confirm that right on the spot is without a doubt the next level, without a doubt.
Yeah, the big focus of this, so obviously this is step one. On the next webinar, we'll be talking about the head tracker, so the maxilla cases, where the mouth is absolutely wide open. And then in the third one, we'll be talking about the mandibular cases, where we've got the wire attached to one of the teeth. Now, you mentioned using orthodontic brackets for doing your tracing at one point. And Ido and you both mentioned the 4 points that are necessary. Just from Ido's presentation and from yours, just to make clear to people, you need 4 high contrast areas. One could be a tooth. We've obviously used orthodontic brackets with George. We've also used healing abutments, and in some cases that I recently did with a very famous oral surgeon in Hong Kong, one of the points we just marked directly on the ridge. There was a landmark that we could see on the ridge, so we just did a very small flap. We used a tooth in the back left, healing abutment in the back right, and then the center of the ridge on the front. So, you can use several things, and you have, correct?
Yes.
Cool.
I don't know if you're talking to me or Ido. Yeah.
Talking to you.
Yeah. Yes. I think the biggest thing is basically just staying true to the game. just basically staying committed. Because it can be, like any new technology, it can be frustrating when you've been doing something a long time one way and you think you're pretty good at it, and then you move into the new technology because it's more sophisticated and you will get better outcomes. There is a little bit of a learning curve. You have to stay true to the technology, and you have to be a student of it, but once you've mastered it, once you've been committed to those 20, 30, 40 cases or whatever it's going to take to get you over that hump, it's kind of like using magnification. It's like it's hard to go back. It's hard to go back to the old way of doing things because it's just dramatically better once you have the workflow down, and once you have that accuracy that's confirmed. There really is I don't know what else how higher you can go unless you're going to start using some sort of brain surgery navigation that's just probably not feasible in our offices. But yeah, I mean, so I would just tell anybody that's starting out that it's just you gotta come prepared. It's not like you can just come and fly by the seat of your pants. Come prepared. Stay a student of it. And lean on Navident, because there are people in the company that want you to succeed, whether that's Ido or Arish or Daron or Beth or Jason. They're all here for your success, not to just sell you a system. And that's one of the reasons why I'm here and a part of this company, because of the quality of the people and the integrity of the company. So yeah.
Thank you very much. I mean, can you imagine? I guess starting from where you started and the 4-step process, what we're excited about and what Ido's new curriculum for our training courses, and then also, George, you're going to be running a training course in September, which I'm going to mention at the end of this meeting. So imagine you're training now, all the time that was dedicated to stents and stent making, which is now gone, can be dedicated to those things you mentioned before, which is planning and the actual surgical practice and the surgical process.
Yeah, and I can't underscore that enough. The problem with our profession is that I don't get paid to plan, Jason. Mm-hmm. I get paid to do surgery. I get paid to take care of periodontal disease, to basically do bone grafting or whatever. I mean, that's what we get paid to do. But it's the thinking part of, what we do that really makes the difference. And so that is really the bottom line. The thinking, the planning, that's really what's going to separate the men from the boys, and those that are successful with this and really are able to take this to the highest level of service to their patients.
Excellent. Well, I'm not seeing any questions thus far. I'm sure it's because you guys were so clear and so concise and explained it so perfectly that I'm not seeing any questions in the Q&A area. So unless anyone has anything specifically, there are questions, says Krista. Okay, I need to see them. I am in the presenter view. Hold on one sec. Sorry, guys. Okay, how does Evalunav work without a pre-op fiducial? How does it work without a pre-op fiducial? Ido?
Yeah, so that, yes. So basically we do not need to have any fiducial in the scan in order to work with Evalunav. What Evalunav does, it simply matches volume to volume. That means it registers 2 scans, 2 CT scans together, based on common landmarks that we manually mark for it, and then it does also the fine-tuning, and we inspect it. So regardless of a fiducial, it can simply do the matching.
Basically, you're importing the pre-surgical plan and you're importing the post-op CBCT, and you're comparing those. So the fact that there's no artificial fiducial in there doesn't matter, and the teeth themselves or whatever you used as your marking points are the new fiducials. Another question from Samuel, edentulous cases, how does that work? So currently we use a 1 mini implant, and we attach the previous arm and the jaw tag to that. But with trace in place, we're very, very encouraged, especially in the maxilla, that we'll be able to choose 3 points, and potentially they could be bone screws or tags. And as I mentioned, at the surgery we did in Hong Kong, we had one abutment, one tooth, and then we just used the center of the ridge. We did a small flap, and we found a landmark on the ridge and used that itself, which encourages us. And George, you can kind of allude to what you let me know what you think about that. But it encourages us to think that we can choose landmarks on the ridge, make a much smaller flap than we normally would have. And as you mentioned, as long as you're very, very careful in going back and forth to those accuracy checks, we may be able to do fully edentulous without anything in the mouth at all.
Yeah. You'll still need to reduce bone. You still have to have access, but you won't have to have, these gigantic flaps like you do when you use, bone-supported guides. I mean, you're still going to have to attend to the principles of, good surgery and make sure that the ridge anatomy is set up properly. But yeah, that's the future. I mean, I've used one of the mini implants. It's a pretty cool technology. It's only going to get better. In terms of, I see a question about the Evalunav does not load if the pre-op does not have fiducials. I'm not sure that's true.
Sorry, you see a question?
Yeah.
Yes. So regarding, I can answer the question. I'm almost certain that this is that's true, and I'm almost certain that it is corrected in the new version of Evalunav that comes with the new Navident. It's basically a very, very simple issue to deal with.
So basically, currently, Dr. Shaw, what you've got is you've got Navident 1.44, 1.45. So we are going to be releasing Navident 2.0 right after this beta section. So we're going to be beta testing. We're currently beta testing. We're going to continue beta testing and hope to release Navident 2.0 with TaP sometime in June after those are completed and we've compiled our results. So yeah, as Ido mentioned, that'll be part of the new. There's no use having it load without a fiducial now, but in the new system it will. Okay. Dr. Burgess got a question regarding potential limitations or contraindications using the head tracker. I don't really think, certainly people had a problem, right-handed surgeons in third quadrant previously, but that seems to be greatly eliminated by head tracker, seeing as the tag is now up here rather than in front of the jaw. Right here. Would you agree with that, George? Any contraindications that you see?
Not that I can think of right off the top of my head. No. I mean, and it's only going to get better. I'm sure that the tag will get smaller and smaller as time goes on. But no, I haven't found any absolute contraindications at this point.
Okay. Ido?
Yeah. So just regarding the question about the Evalunav, so Arish just confirmed to me that it's so only in older versions. In the newer version, there is no issue with importing a scan, a pre-op scan with the plan without a fiducial.
Arish is one of our main developers, kind of in charge of, and you can just see the response time right here. That's exactly the same response time that you get from Arish if you have a question, or from Nima or Ido or anyone on our Anna, anyone on our support team. Okay, I don't see any more questions. Can leave it open for another minute or two. Looks like we're kind of scheduled to finish at 7, so I can talk about our next 2 webinars really quickly, and then I can just mention the 2 courses, the 2 opportunities that we have coming up. So as far as the 2 webinars, first of all, the next one will be on May 9th at 6 p.m., So those of you who registered for this one, that will be on the maxilla. So we'll much more detail go into focus about the cases of the maxilla. I think we answered a lot of your questions here, and you've seen a lot, but that'll go into more detail. And then the following on the mandible will be on May 23rd at the same time, 6 p.m. So thanks very much for that. We'd like to mention first George's course. It's a full-day course on September 15th. It will involve live surgery, I believe. Correct, George?
Yes.
Yeah. So that's in Chicago. It's wonderful. And how many people is that going to be open and available to?
I think somewhere between 7 and 9.
Okay. Okay, so I think we've got 1 or 2 signed up already. So that's September 15th. And then previous to that, if you're more in the southern United States, we've got a course with the McGuire group. That maybe is the previous, yeah. So with the McGuire Institute on June 8th, the Perio Health Professionals down in Houston, and they will be putting on a very similar workshop. George is very familiar with the McGuire group, and they work together. So they're both kind of pioneers, George starting first and the McGuire group following along, and Todd Shire leading the way there for them, and David Lipton, Mike McGuire, the surgery. So either one, if you're interested to learn immediately, obviously you're going to watch our webinars. We have some education here in Toronto that you can check out, but like very, very greatly encourage you to go and see an expert such as George on September 15th or the McGuires on June 8th in their office. And seeing experts go ahead and do the surgery makes a huge difference. Okay. So I don't think we have any more questions. Let me check the chat down here. Dr. Burgess is asking a question, and yes, that's exactly what we think. So he's talking about 3 small bone screws in a fully edentulous jaw give adequate reference markers to a flapless surgery in edentulous cases. And yeah.
I'm just not a big fan of flapless cases. I mean, perhaps because, I mean, my experience is that, you know, you need a little bit of a flap. Otherwise, you're basically blowing out all the attached gingiva around, you know, that you have. So I think to keep it minimally invasive is key, and that's definitely the future. But just be mindful of, you know, the attached gingiva that's in the area so that, you know, you don't end up with mucosa all around your fixtures. And you could just have, you know, at least the zone of attached gingiva.
Okay. All right. Well, thank you all very much for being here from all over the globe. We appreciate it. If anybody has any other questions, certainly you can email myself, George, or Ido, or anyone else on the Navident team. We'll be very happy to hear from you and listening to you. Very interesting, offering any CE credits. Any CE credits, Beth? Beth can answer that question. I believe so. Oh, for the courses, yeah, there's CE credits for the courses, I believe, absolutely.
Yeah.
So Beth Boudreau is beth@claronav.com. She's in charge of these CE courses for us. So again, beth@claronav.com. You can email her. Any one of us here at the company, it's basically our first name @claronav.com. So Ido, IDO, Jason, you can talk to Anna and Nima in customer support, and they'll be happy to answer all your questions. Okay? So it looks like it's 7 o'clock. We'd like to thank everyone again for attending. We appreciate it, and we hope to see you soon see you again on May 9th. And again, if you have any other questions, please let us know. Thanks, Ido. Thanks, George. Appreciate it.
Thanks, guys. Okay, good night. Good night, everyone.
Bye-bye.
Hi, Keith. Bye, guys.
Bye-bye.
Sub-conference rooms are open.